Hello, my name is Ken Cutbush. I'm a Brisbane orthopaedic surgeon. I'm a specialist shoulder surgeon. Do you have frozen shoulder, or does someone that you know have frozen shoulder and you want to know what the treatment options for you are? In this video, I'm going to run through the treatment options of frozen shoulder. I'm going to talk briefly about frozen shoulder itself, and then I'm going to go on and talk about the different options for treatment and what we're trying to achieve, including physiotherapy, cortisone injections, hydrodilatation, manipulation under anesthesia, and of course, arthroscopic release of the shoulder. Frozen shoulder is a common condition. It affects 2% of the population, and in patients with diabetes, it affects up to 20% of them. In 30% of patients, they experience frozen shoulder bilaterally. Frozen shoulder is a condition that may occur spontaneously, or it may come on after an injury, a traumatic injury, or after surgery. It starts as an inflammation of the capsule. That capsule becomes inflamed and hyperemic, and it precipitates thickening of the capsule. And that thickening, that contraction, that fibrosis of the capsule, wedging the ball of the shoulder joint into the cup of the shoulder, is what reduces the range of motion and causes the stiffness that patients experience. In its early stages, frozen shoulder is commonly diagnosed as impingement. Impingement is another very common condition that affects the shoulder. However, patients with frozen shoulder become stiff and they are unable to impinge. Eventually, frozen shoulder resolves of its own accord, and in at least half of patients, they regain all of their range of motion. However, it takes often 1 to 2 years for this to occur, and sometimes it takes even longer for the frozen shoulder to resolve. Due to the common relationship with diabetes, I usually recommend to patients that they see their GP to consider getting a fasting blood glucose check so that they can rule out diabetes as a condition for them. The cause of frozen shoulder is unknown, and as such, there's no treatment aimed at curing the condition or reversing the condition. What we can do is treat the symptoms, and the symptoms are well known to the patients. They are pain and stiffness. The pain of frozen shoulder is due to the inflammation of the capsule, the capsulitis, and a cortisone injection given into the shoulder joint, into the glenohumeral joint, not into the bursa, can be very effective at reducing that inflammation. The cortisone injections are true anti-inflammatories. The local anesthetic that is usually given with the cortisone will numb the joint for several hours, and that response to the local anesthetic injection into the joint is very helpful in giving more support to the diagnosis of frozen shoulder. Cortisone works as a true anti-inflammatory, reducing the inflammation in the shoulder capsule and hence alleviating the pain. Cortisone is a real anti-inflammatory and has very potent effects, unlike the more common anti-inflammatories that we know, which are the tablets like aspirin and Nurofen, which have only very weak anti-inflammatory effect and are not particularly helpful for patients with a frozen shoulder. The cortisone used is usually betamethasone, and that's a fluorinated cortisone molecule. The fluoride group on the cortisone gives us really powerful properties, significantly enhancing the effect of the cortisone molecule. These steroid medications are also available in tablet form, and in tablet form, patients often take them for several weeks or even months at a time, and in that situation, side effects are very common, and the side effects can be quite significant. Side effects such as weak bones, increased susceptibility to infection, and weight gain are very common. However, when it's given into the joint, that dose is similar to about the same amount of cortisone that you would take in a day in tablet form, and you're only taking it as a once-off. So the risk of side effects is much, much smaller than if you were taking it as a tablet. I usually recommend that patients have 1 injection to start with. Sometimes patients will benefit from more than 1 injection, but it would be rare that I would suggest that a patient have more than 3 injections, and even then they would be spaced about a month apart. The other risk to remember for an injection into the shoulder is the risk of introducing bacteria into the joint from the skin. It is possible with these injections to precipitate an infection of the shoulder joint. However, this is exceedingly rare. There is some evidence that a cortisone injection given for frozen shoulder into the glenohumeral joint does have some effect to reduce the length of time that the frozen shoulder lasts for and to speed recovery. Hazelman and his co-authors reported in the Journal of Rheumatology and Physical Medicine in 1972 that their patients suffered from frozen shoulder for a shorter period of time after having had a cortisone injection. Dias and his co-authors reported in 2005 in the British Medical Journal, the BMJ, that their patients improved from the cortisone injection as the cortisone injection reduced the capsulitis and hence probably sped the recovery from the frozen shoulder condition. Sun and his co-authors published a systematic review in 2016 in the American Journal of Sports Medicine looking at 8 randomized controlled trials totaling a total of 416 patients. They concluded that pain scores and range of motion were significantly improved in patients and that these improvements were seen up to 26 weeks after the cortisone injection. Hydrodilatation combined with the cortisone injection to the glenohumeral joint is a time-honoured technique which has been recommended for years for patients suffering from frozen shoulder. However, in more recent years, it is not being used anywhere near as much. Personally, I don't recommend hydrodilatation for my patients. Hydrodilatation is forcing the cortisone injection and the local anaesthetic under pressure into the shoulder joint inside the capsule, hoping that the capsule will get stretched or will tear in response to that injection. It's very painful, and there's no evidence that hydrodilatation is any better than just doing a cortisone injection on its own. This stiffness seen in patients with frozen shoulder is related to the thickening, contraction, and fibrosis of the shoulder capsule. It pulls the ball of the shoulder joint into the socket and holds it there so it can't move, thus reducing the range of motion that the patient experiences. Now, in almost every patient, frozen shoulder will eventually resolve, although in some of those patients they don't get all their range of motion back. For me, I recommend to most patients they consider waiting for the shoulder to resolve its own accord. However, many patients are severely limited in their range of motion, and this would mean for them not working until the shoulder resolved and not engaging in their normal pastimes, normal sporting activities and recreational activities until the frozen shoulder resolved. It can take several years for the frozen shoulder to resolve, and so for some people, waiting for the stiffness to resolve its own accord is not a particularly good option for them. In these patients, I discuss with them the role of an arthroscopic release of the shoulder. An arthroscopic release is a surgical procedure, and for me, that involves a 360-degree complete release of the capsule. What that does is put an incision in the capsule so the ball is no longer held fixed tightly in the socket, and it's able to move like it did before the frozen shoulder actually occurred. Surgery is effective for restoring 70 to 80% of the range of motion immediately post-operatively. The remainder of the range of motion comes back as the frozen shoulder condition burns itself out. The original arthroscopic method for releasing the shoulder involved releasing the most severely affected part of the capsule, but not all of the capsule. The reason for this was mainly due to concerns that shoulder instability would be induced by a complete release of the capsule. However, a partial release of the capsule is not as effective at restoring range of motion as the complete 360-degree release that I currently perform. When I started doing this procedure, the 360-degree release, several years back, I commenced a research project where I followed every patient that I operated on and watched their results. What I've found from watching those patients is that none of the patients developed a complication. And while no surgery is completely complication-free, this 360-degree release of the shoulder is safe. It's very effective, with the majority of patients getting 70 to 80% of their range of motion back immediately post-operatively. The procedure also has the highest patient satisfaction ratings of any of the operations that I follow. The success of the more extensive 360-degree release of the shoulder capsule has been shown in other research projects. Datani and his co-authors published in the Bone and Joint Journal in 2016 a series of 100 patients who had failed non-operative management and in whom they went on to perform an arthroscopic 360-degree capsule release. They found that 6 months post-operatively, there was a highly significant improvement in range of motion compared to patients treated non-operatively. Physiotherapy is a very valuable treatment option for patients with shoulder conditions. It's particularly helpful for patients that have frozen shoulder in two scenarios. The first is immediately following an arthroscopic release of the shoulder, when patients need a fairly intensive regime of physiotherapy to make sure that the shoulder doesn't tighten up again. And the second instance is in patients who are treated non-operatively when they start to regain their range of motion in that thawing phase of their condition. Physiotherapy is not so helpful in the early freezing phase of the condition, as it can aggravate the pain and the capsulitis. Dirks and Stevens published a paper in 2004 in the Journal of Shoulder and Elbow Surgery looking at intensive physiotherapy for patients with frozen shoulder. They found that intensive physiotherapy in that early stage of frozen shoulder appeared to prolong the condition and stretch it out from an average of 15 months towards 24 months. Manipulation under anesthesia is another time-honoured technique to treat patients with frozen shoulder. Manipulation under anesthesia, or MUA, is where the patient is given a general anaesthetic, and while they're asleep, the shoulder is manipulated through a range of motion to forcibly tear the capsule. For me, the incision of the capsule as a clean surgical procedure under direct vision using the arthroscope is a more effective and, for me, a safer technique than the uncontrolled manipulation under anaesthesia. In conclusion, as we don't know what causes frozen shoulder, there is no treatment that can be given to address the cause or to cure the condition. What we can do is treat the symptoms, and the symptoms are twofold. They're pain and stiffness. For the pain, a cortisone injection into the glenohumeral joint is very effective in helping reduce that level of pain, and there is some suggestion that the cortisone injection may in fact shorten the time of the frozen shoulder and hastens its recovery. For the stiffness, often the best option is wait for it to resolve of its own accord. For some people who are very stiff and unable to do their normal activities or go to work, they may consider an arthroscopic release of the shoulder. This is a surgical procedure that for me involves a release of 360 degrees of the capsule and frees the ball joint from the socket, allowing range of motion to then occur. It's a safe procedure and restores about 70 to 80% of the range of motion in most patients, with the remainder of the range of motion occurring as the frozen shoulder burns itself out. It's a procedure that has a high satisfaction rate. So I hope you got a good understanding of the treatment options for frozen shoulder, and you heard from me my preferences in how to treat frozen shoulder. Thank you.